In this scenario, we're administering a medication to a child over 20 kilos via a regular Alaris pump, not a syringe pump. This child has no maintenance IV fluids. They're eating and drinking. They simply need the pump for occasional medication administration. So this is called an INT, and it's a central line, a PICC line, which is what most of the kids have. The student is doing some of the safety checks. Again, checking the medical record form against the child's ID band. We also have the child's name and hospital number, medication on the IV bag of medication. So we're going to check all that. We're going to check with the parents to make sure that this is the right medication, that they can check us and that they can be informed. And we look on the little piggyback bag and we see that we're going to administer cefazolin, and that's exactly what was in the previous bag. So in this instance, we don't need to worry about any conflicting medications mixing inside the tubing. So we can simply put our new piggyback bag onto the tubing. You either have to close that slide clamp or hold it above your head, or else the medication will backflow and you will have a mess. So the student's going to get putting the new medication bag on. Now we're going to program the pump. We punch system on. It does a little self-check, takes just a couple seconds. And in order to program a flush, new patient, no. Pediatric profile, yes. And in order to program a flush for our med and the med, after we tell the machine what channel we're using, we're going to punch basic infusion. Now, the primary infusion is going to be the flush that goes in after our medication has completed its infusion time. The selection here is important. It takes about 25 milliliters to completely flush the long tubing, and we want it to go over about 15 minutes. So our rate's going to be 10 or 15 minutes. We're going to run it at 100 or 125. Now we come to the child's site of access, and we're going to check for patency a couple of ways. We're going to tell how easy it is to flush it as we manually flush it, and we also may want to, just once a shift or so, check for a blood return. So we open a new supply of 10 milliliter syringes of pre-filled saline. Going to get rid of the air bubble. Put the cap back on just to make sure it stays nice and sterile. This is going into the child's central line right up near the superior vena cava. So we don't want any germs up there. And we're going to then use our alcohol wipe to vigorously scrub the extension part of the access. We don't scrub the part that goes into the child's skin, because we don't want to disturb that and compromise its patency. So we're going to go into the extension part, firmly pushing and screwing on the saline. Then we unclamp once we have our syringe on. They should be clamped at all times unless the syringe is screwed on firmly onto the access. Once it's unclamped, see the student pumping with a brief little bump, 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 bump methodology, trying to, and here he's going to pull back and check for a flash of blood return. Once we see a tiny bit of blood, we know we've got a good open line. If we don't, it still flushes easily. We can use it anyway, but we want to let someone know about it. So once we have seen a little flash of blood come back, we're going to finish our flush so that we end up with 5 milliliters flush. That's standard for all of the PICCs and central lines, no matter what size the child. And as we continue pushing with positive pressure, that's when we would like to slide the clamp closed. It takes a bit of coordination, but that prevents blood from flushing back up into the line if you can clamp while you're exerting positive pressure. Now it's time to attach the line to the pump that we've already programmed. And it's out of the scene. Now, see that access site's not touching anything, so we don't have to re-wipe it with alcohol, as long as it's just dangling in the air. Okay, we attach the tubing, we open our slide clamp, and now it's time to go back to the machine, and it's going to be on the secondary, because that's the medication that goes first, and we can punch restart channel. We punched start and pause so the machine wouldn't be beeping, beeping, beeping at us while we were flushing the line. So we've got the secondary medication running, and we know that after that's complete, our primary flush will go, and the med will be out of all the line and into the child, and we see it's dripping, so we know we're correct. Infusion is now complete for both the secondary and then the primary flush. So we come in the room with our supplies at hand to be ready to de-access this PICC line. We go to the machine, we punch power off very firmly with our thumb until we hear a quiet little beep, and then the machine will power down. Since this is a central line, we can't use just saline to flush our line. We use saline and then a very dilute heparin flush. So we're looking at our supplies here, and we have alcohol, and we have a little cap that we're going to need to keep the IV line itself, the long line, sterile and airtight until we want to use it next time. We have our syringe of saline for flush, and we have our misspelled syringe with 1 milliliter of heparin. It's 10 unit per milliliter heparin. It's just a drop in the bucket. So we clamp, and we de-access our line. Oh, he's first going to get his materials ready. So we're going to open the syringe of flush, get our bubble out, as always. It's really easier if you pull back on your syringe to get the bubble out. There's a little diaphragm in there that needs to be broken before you can get the bubble out. So pull back first and then get the bubble out. Cap it to keep it sterile. Open the little, I call them white caps. I don't know what else you would call them. And we don't use the blue part. It looks like it's packaged to use the blue part, but that's excess. And we only want the little white female end on the line protector. So he's readied that. It's clamped. He's making sure of that. We unscrew the line. Now the part that's in his right hand is the part that must not touch anything, or else we have to throw our whole IV setup away. We don't care about the little access INT part because we're going to scrub that with alcohol anyway. So he's getting the little white cap, and see how that is used to keep that line sterile and airtight, because the lines you can use for 72 hours. So we'll use it the next time. Just move that out of the way. Anywhere is fine because it's protected now. We're going to scrub our extension access attachment. And you scrub the threads as well, because you're going to be screwing your syringes into that self-closing port. It's not touching anything, so it's still sterile. In we go with our saline. Now that the syringe is attached, we can unclamp. And for PICC lines, pretty standard to use 5 of flush. And again, we're going to do the little pulsing action. Research has shown that you have less red cells flushing back into the line if you use turbulence. We really do not need to check for blood return again because we've already done it once a shift. So we're going to end up with a total of 5 flushed in. Clamp as we're exerting positive pressure. And then we're going to trade that syringe out. We are going to trade that syringe out for the syringe with the 1 milliliter of the dilute heparin. That's what's going to hover around the end of that PICC line and keep the red cells and other platelets, blood products from forming a clot. So the heparin's on. Now we can unclamp. Bump, 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 bump. Sliding closed if you're coordinated with positive pressure. And we are finished until time for the next medication. Clamped, and we're off our way.